Today, we're going to decode one of the most complex, most important, and honestly, most misunderstood structures in the entire human body, the TFCC. This is all about some incredible biomechanical engineering, a bit of diagnostic detective work, and figuring out what separates a minor sprain from a lifetime of pain.
Think about it. Every single day, you do things like turn a key, open a jar, use a screwdriver. You're constantly rotating your forearm, turning your palm up, that's supination, and turning it down, that's pronation. These movements feel so simple, right? Almost automatic, but they are powered by this unbelievably sophisticated little engine inside your wrist.
But what if that just stopped? Imagine a sudden pop or a sharp, nagging pain on the pinky side of your wrist, and now every time you turn a doorknob, it's just agony. That invisible little structure that makes it all work, it's failed. And that's the mystery we're diving into.
To solve this mystery, we have to look at the wrist's hidden engine. And no, we're not talking about the big, obvious bones you can feel. We're going way deeper, to the precise joint that allows all of that incredible rotation to happen.
Okay, so this is the distal radial ulnar joint, or the DRUJ for short. It's simply the meeting point of your two forearm bones, the radius and the ulna, right down at your wrist. You can think of it like an axle. And for that axle to work smoothly, for you to rotate your hand, it has to be perfectly, absolutely stable.
So what keeps it stable? Well, this is the hero of our story, the triangular fibrocartilage complex, or TFCC. The best way to think about it is like a high-tech little hammock made of tough cartilage and ligaments. It basically cradles the end of your ulna, connecting it to the radius, and it is the primary stabilizer for this whole joint. Now, to really get why this thing gets injured so often, we first have to appreciate how this amazing structure actually works. See, it's not just a static piece of tissue sitting there. It's a dynamic, living system.
You can really see the dynamic tension at play here. When you turn your palm down into pronation, the ligament on the back of your wrist, the dorsal one, tightens up like a guide rope. Then when you turn your palm up into supination, the ligament on the front, the palmar one, takes over and tightens. It's this perfect push-pull system, and it's not even working alone. Other nearby structures, like the ECU tendon subsheath, also chip in as dynamic stabilizers, constantly adjusting to keep that joint secure.
So, when a patient comes in with that classic pinky-sided wrist pain, the doctor basically becomes a detective. A lot of them use what's called the Four-Leaf Clover concept, described by doctors Kakar and Garcia-Elias as a way to systematically check all the key structures that could be causing the trouble. It's a really clever approach.
The first clues almost always come from hands-on tests. With the DRUJ ballottement test, the examiner holds the radius bone steady and gently tries to move the ulna up and down. If there's way too much movement, or if it feels kind of soft and mushy at the end, that's a huge red flag that those deep, critical TFCC fibers have torn.
And then there's this, the fovea sign. Now, the fovea is just a tiny little divot at the base of the ulna where the deepest fibers of the TFCC attach. If a doctor presses on that exact spot and it causes sharp pain, that is an incredibly specific clue. It points directly to a tear right at that critical spot. This isn't just general wrist pain. It's pinpoint tenderness, and that distinction means everything.
Now, while some TFCC problems are from slow wear and tear over time, many of the most severe cases happen because of a single traumatic event. And you know what the most common one is? A broken wrist.
Just look at the difference here. On the left, you've got a normal wrist. You can see those clean lines, perfect alignment. But on the right, that's a whole different story. That's what we call a comminuted intra-articular distal radius fracture. Comminuted means the bone is shattered, and intra-articular means the break goes right into the joint itself. That kind of violent disruption can easily tear the TFCC, creating instant, serious instability.
And the consequences if that fracture doesn't heal just right?
Well, they're staggering.
Yep, you saw that right. A landmark study by Nirk and Jupiter found that if that joint doesn't heal perfectly, if there's even a tiny step off on the surface, a painful, debilitating arthritis down the road is almost a guarantee. This is why surgeons are so obsessed with getting that smooth joint surface back. In fact, even if a fracture heals but it leaves the radius a little bit shorter than it should be, that can put chronic stress on the TFCC and cause it to tear over time.
So, how do you actually see a soft tissue tear that's hidden deep inside the wrist? And how do surgeons talk about these injuries to make sure they're all on the same page? Well, that's the next step in our diagnostic journey. Now you might think, just get an MRI, right? That'll show everything. Well, it's a bit more complicated. For a long time, as this older quote shows, standard MRIs really struggle to see these tiny, complex ligaments. The good news is that today's high-resolution MRIs, using a special small joint coil, are a vital and much more accurate tool, but even they have their limits sometimes.
To bring some order to the chaos, surgeons use what's called the Palmer classification. It's basically a map of the injury. Class 1 tears are from trauma, and those letters, A, B, C, D, tell you exactly where the tear is located. What's so cool is that the groundbreaking microanatomy work by Dr. Nakamura showed us exactly what's happening at a microscopic level in each of these zones, which fibers are for stability and which are for shock absorption. It helps surgeons understand the real consequences of each specific tear.
So, given that imaging can sometimes be tricky, the true gold standard is arthroscopy. A tiny camera is inserted right into the wrist joint. This lets the surgeon not only see the tear with their own eyes and classify it with 100% certainty, but they can often repair it right then and there in the same procedure.
And here you can actually see it in action. It's incredible. On the left, the surgeon is carefully passing sutures through that torn edge of the TFCC. And on the right, that's the final result. The tissue is anchored right back down to the bone where it's supposed to be, restoring that absolutely crucial stability to the joint.
And the science just keeps getting better. A surgeon named Dr. Atse developed an even more detailed grading system, specifically for those deep foveal tears we talked about. This isn't just academic stuff. This directly guides the surgeon's hand in the operating room, helping them pick the absolute best repair strategy for the exact injury they're looking at.
So why do we care about all this detail? Why does it matter so much? Because not all pain on the pinky side of the wrist is the same thing, and getting the diagnosis exactly right is everything. For example, a doctor has to figure out if it's a TFCC tear or something called ulnar impaction syndrome. With impactions, the ulnar bone itself is just a little too long, and it literally bangs into the other wrist bones. A key clue is often in the patient's story. Pain from a TFCC tear often gets worse with supination, like turning a key, but pain from impaction often gets worse with pronation and loading, like pushing yourself up out of a chair.
And this right here is the main point. This is the big takeaway. A TFC tear is not a simple wrist sprain. If you ignore it, if it gets misdiagnosed, you're not just looking at a little extra soreness. You could be looking at a future of chronic instability, painful clicking, weakness, and eventually a disabling arthritis that can completely rob you of your ability to function.
It really leaves you with a critical question, doesn't it? How many serious, treatable wrist injuries are out there, hiding in plain sight, just being dismissed by everyone, patients and sometimes even doctors, as just a sprain that'll get better on its own? It's a powerful reminder of the incredible, complex machinery hiding just under our skin, and why it's so important to listen when it tells us something is wrong.